RN Link presents Clinical Documentation Integrity Metrics webinar presented by Anne-Marie Gould, RN, CDIP and AHIMA approved CDI trainer, and Christy Zielinski, RN, CCDS. Provider approved by the California Board of Registered Nurses for 3 contact hours, AHIMA for 3 CEUs and ACDIS for 3 CEUs. Just click the links on the description below after the presentation.
All right, so welcome to Clinical Documentation Integrity Metrics. Our learning objectives for this session, at the end of this training session, the CDI Specialist or coder will be able to, 1, understand what clinical documentation integrity is all about. So we put in, we're going to discuss the role of CDI with team members, physician advisor role, queries and coding regulations. We're going to go into defining metrics and key performance indicators, review types of metrics used in CDI today, discuss current benchmarks within USA, and understand query processes and how they impact metrics and key performance indicators. And then we have a few case scenarios that may impact metrics. And when we're looking at the case scenarios, we're relating metrics to the CDI Specialist. Okay, so we'll have a great discussion. And then any questions and answers. Like I said, just if you have a question about something, please don't hesitate to jump in. We keep our training sessions very informal here. Of course, our disclaimers. The presentation is designed to provide tools to communicate information about clinical documentation, coding, and compliance in an educational structure. The presenter or presenters in this case are not providing or giving legal assistance or advice, but offer sensible and useful information and tools to obtain compliant results in the area of clinical documentation and coding. The educational materials provided in this presentation are carefully explored for its accuracy and usefulness, and best practice results in achieving outcome will differ in each hospital, facility, and clinical situation. So let's just go into clinical documentation integrity overview. So what is clinical documentation integrity, or CDI? Well, CDI encompasses clinical knowledge, medical procedural coding, and medical record coding regulations. CDI programs have been instituted within the inpatient as well as outpatient settings today for most of the healthcare organizations. It involves medical record review of hospitalized patients for high-quality provider documentation relating to the diagnosis associated for that patient. And it provides coders the highest degree of diagnosis specificity for billing purposes. CDI programs not only provide accurate reimbursement, right, for the hospitalized patient, but we also provide the highest documentation standards in order to improve the patient's quality of care. What's the old saying? If it's not documented, it wasn't done, right? That still rings true today in any healthcare organization. And CDI programs use a multidisciplinary approach. There are other hospital departments involved, along with the CDI specialists, the coders, and even your other HIM professionals within the office. So the team, as you can see, there's a lot of different teams that we have. CDI, I said it takes a village to make a CDI program work in a hospital setting. And we are just mainly speaking about inpatient settings. We're not going to delve into outpatient in this particular webinar. But as you can see, there's a lot of people involved, not just the specialist coders and HIM professionals, but also your providers, right? Or big because that's who we work with side by side. We also work with coders though, so CDI as a CDI specialist, you have a dual role. You're educating providers on one side, but then you're making sure that the diagnosis specificity is there for the coders when the patient is discharged from the hospital. You also work with quality management, case management, or care coordination, your nursing and nutrition departments, even radiology, as well as senior leadership. And I think that's the biggest piece of the pie. If you do not have buy-in with your senior leadership team, the CDI program may not survive in that facility. And unfortunately, when CDI was just starting out, when I was starting out in CDI, I've seen a lot of small hospitals disband their CDI program because the senior leadership really didn't understand what impact it may have within their hospital organization. When it comes to working with quality department, your quality, they're looking at your hospital acquired conditions, your patient safety indicators. That's another big piece of the pie, right? That's looked at today, not just by CMS, but a lot of external organizations out there, quality organizations. So you always work with them when it comes to certain topics with relating to your patient safety indicators and also your hacks. Your case management care coordination department, usually we're looking at them. They're in charge of medical necessity, right, for that inpatient stay. That's what they're in charge of. And they talk to the doctors. It's like, well, what's the discharge plan for this patient, right? But we also work with them when we're assigning our DRG, our working DRG assignments. We have the geometric mean length of stay listed in our DRG. So we work side by side with case management as well. I know we used to, and Henry Mayo, we would work with case management to give them our working DRG assignment because they had a program that they instituted on each unit. They were working with the med surg units, where the case management director, she says, I just want you to come up here and just write on the whiteboard what your DRG is and the GME, the length of stay associated with that DRG. So it was multidisciplinary rounding. She even had the providers come in, give a rundown of each of the patients. So it was multifactorial, that's for sure, with the rounding that we did. And that was started the year before I left. So hopefully that's still going. Debbie, is that still going? I'm not sure if they're still maintaining that.
Well, we lost our case manager director. I'm assuming it's still going on because I hear rumblings of it, a little bit of talk about it.
Yeah.
I know they tried to get us involved, but that with the MDR rounding, but that didn't work out very well. And that mainly was because where they did it was such a small department and we were still kind of getting through the COVID. That was not a smart,
not feasible
at all. So we were pulled out of it, and but I believe it's still going on. I think Ronnie has said that, but I'm not positive.
Okay. All right. Patricia or Kim, do you guys do any rounding, any type of rounding in your current role with the providers or with other departments in the hospital setting?
Hi, this is Kim. We're remote now, but we did. When I first started, we used to round with physicians. If we had query questions, we actually would go meet with them. And we just education with them. But since we've been remote, we really don't. We do Teams calls with them.
I was going to say, okay, yeah.
And we work with a lot of the residents now.
I was going to say, do you have residents and fellows and whatnot? So
yes, we're an academic medical center. So yes, we've got all the layers. We've educated nurse practitioner, all the advanced practitioners. So they're getting in the loop now to help us with query response now. And
Oh, that's
we're
great.
for case care facilitation, so we have the case management with us now. And then we work really close with our HIMS department.
Oh, yeah, absolutely. Well, that's great. That's great to hear. Like I said, it does take a village.
Yes,
I know
does.
with nursing, we were setting up, there were a couple items, because it's all electronic now. I feel like the nurses are task oriented now with the electronic record. It's like, just click off the box. I was like, wait a minute, guys, come on, look at the whole picture of the patient. And we had a couple issues where we ended up having to report to Coda Caudy, that was not present on admission. So it was a hack. And I was like, you guys, I said, the documentation wasn't there. It wasn't there to support that it was present on admission. And even the provider says, when I spoke to the physician, the hospitalist at that time, and I said, hey, I said, do you think this catheter was placed in the ER, or was it, placed in when the patient was admitted? Or did he come in the door with it? And he goes, Anne Marie, I don't know. I said, and I don't see any documentation from the nurses in the ER or by the nurses on the floor if he did have the Foley catheter in there. I said, right. So nothing was documented. And unfortunately, we did have to report that hack.
Yeah, we deal with
And that's a big thing, right, Kim? That's where you work with your quality hand in hand. You really don't want to report hacks. Absolutely not.
No, you
That's
don't.
a big ding. Yeah.
Huge
And
thing.
you go ahead.
It's a huge thing.
It is. It's really big. That's like your patient safety indicators today. Your PSI 90. That's all your post-op, post-procedural diagnosis that develop. I think of post-op respiratory failure all the time, comes to mind, and that PSI 90 piece, because it's such a big thing. You're dinging, and when the medical doctors are writing that, they're dinging, and they don't understand that piece. And I think it's really important as a CDI specialist. It's like, hey, let's have a conversation about your words. Let's discuss this, please. Because
Exactly.
they don't understand repercussions, right, when they're documenting certain things a certain way, but they're using it as a timestamp post-op, and it's not a complication of the procedure. So we usually give them different little other keywords or verbiage to utilize.
We're still seeing that as a little bit of an issue because they'll just say post-op, and to them, like you said, it's just a timestamp of occurring after a surgery, but it's not necessarily a complication from that surgery or a respiratory complication post-op. They just had some respiratory failure, but not as a complication.
Right. And
And
that's the
the
thing.
ED thing is still big. We're still working. And when I don't go to ED as much as I used to, just because our emergency room is nuts. And I go down there with good job cards for our ED physicians, but those nurses don't need me in their way. It's, patients in the hallway, they don't need me there to discuss. They're working. So now we go through their current supervisor because they're forgetting to document when that patient comes in with a Foley catheter, and they are forgetting to document HOMO2 amount. And I had brought it up the other day. I said, it was documented by the ED, but not the amount. So I went to looking for the summary. And the patient, and it wasn't documented there, but the patient was actually on 3 to 4 liters at HOMO2, and that's a pretty good amount for HOMO2. And I'm like, they documented the COPD and everything else, but as a nurse, would you not ask if they were on HOMO-2? Is that like forgotten? And I think that goes to what Anne Marie says of just checking off a box. They're not
Yeah.
thinking about, okay, the patient has HOMO-2, but what is the amount? Why are you not asking that question? So we've been trying to work with them some more.
Well, that's good. That's good.
Yeah. Sometimes you find that. I mean, I don't find in nurses' notes, but when I see like the case manager's note or the social worker,
Yeah.
unless that's the only time I will find out what equipments the patient is using at
Yeah.
home.
Yeah.
Mm-hmm.
It's and everybody's busy, but you can't let busy take away from good charting and good documentation.
Mm-hmm.
Right. Absolutely. I know at Henry Mayo, we did work with case management because in their DME section, either the case manager or the social worker, they would list if they're on what type of DME, right? In
Mm-hmm.
their initial review for discharge planning. And I know we had a little text box that, if they were on HOMO-2, they would give us the liters per minute. But also nutrition too. Nutrition is a great department to work for your malnutrition or your obesity, right? Malnutrition is one of the red flag diagnoses, right? I think for all facilities across the board because of all the OIG audits that are being performed for severe malnutrition. And our nutrition department, we were in the process of working with them to complete a template where they can have their note signed by the provider that they agree. And
We have it in
unfortunately,
place now.
that didn't come to fruition, unfortunately, because when I left, and I heard the manager left too after I left, so
But
we
it's
never
in
got that
place
up
now.
and rolling.
So it goes into other reports and the doctor signs it, or if he disagrees, doesn't sign it.
Oh, okay, good.
Yeah, it's great because
Oh, wonderful. I'm glad they did move forward with it then.
Yep,
Okay,
they
great.
did.
And then, of course, radiology, whenever you speak with your radiologist, they're indirect physicians, providers for the patient. So you definitely want to bring anything that's documented within the radiology that you feel that it's a diagnosis that's definitely supported and the provider, the attending provider is not documenting that. You definitely want to clarify that with the provider, the attending physician. All right.
This is Patricia. I find that physical therapy, occupational therapy, and speech language pathology provide some good insight, especially physical therapy, where I found that the patients on HOMO-2, if there's any behavioral issues, as well as any issues with hemiplegia. Also pathology, sometimes I can query off the pathologist because we cannot accept the diagnosis of pathology, so we have to ask the physician if he agrees with it.
That's right. Very good. Thank you for sharing that, Patricia. Yeah, your therapy notes are they're great information. They give you a lot of information, especially and they're on the, especially if you review cases in acute rehab. Do y'all review cases, charts in acute rehab by chance?
No, I don't. I only do physical therapy because I do acute hospital, but I find that they have very good information regarding how the patient is doing, like respiratory-wise. I find
Right.
the physician sometimes doesn't document as well regarding that, but the physical therapy will tell you, hey, he cannot walk a certain distance. They'll even do oxygen testing, which can help me get a chronic respiratory failure.
Right. Right. Excellent. Yeah. Yeah, and definitely about the path report, you always got to send a query if the doctor doesn't see it. And most times your path report, your final report isn't back. So usually as a CDS, we're sending it post-discharge. Now, for your programs, Patricia and, excuse me, Kim, that you work as a CDS, do you send queries for the coders when the patient is discharged, or do the coders send their own?
It all depends on when I get my chart. If it's within a few days and the and the coder has not, let's say the doctor doesn't answer correctly on a pressure, well, maybe he answers 2 out of 3 on the pressure ulcer, okay? So I'm going to want to get the third one because that's important. I can query on that because the coder has not coded it. If she's already coded it, then I have to let her go in and do that.
Okay. So your coders will send post-discharge queries. Okay. Because there are some places that, and I worked, Debbie can attest to this, at Henry Mayo, we had to send the queries post-discharge for the coders. They would reach out to the CDI team, whoever
That's how-
reviewed that case.
Yeah, that's what we have to do. We send the queries for the coders.
Okay, you send them as well, Kim. Yeah. Some facilities will have the coders send it, like the current contract company I'm working with, their coders, once the patient is discharged, their coders will send a query. But if they're not sure about it, what clinical indicators to put in, they will refer it back to the CDI who reviewed that case, the CDIS, and they will ask for assistance, and then the CDIS may submit it for them, may send it for them. So it depends. Like I said, every facility is different. So you really want to know what your query processes are, that's for sure. Okay.
Yeah, like in the previous facility I used to work, once the patient's discharged, we're not allowed to touch the chart. It's up to the coders. So if there's query pending, we can't even look at it. I mean, we need to know, like on the day of discharge, whether the patient responded or not. And in regards to query, yeah, once the patient is discharged, it's the coder's responsibility if they want to query or not. So yeah, it all depends on facilities. Yeah.
Yeah, absolutely. All right. Great discussion, ladies. Okay, so as we know with quality documentation, it hits a lot of different areas, right? As we know, your severity of illness and risk of mortality data points, your RAC audits and compliance, POA status is a big thing, right, for us to make sure we don't have any hacks on that record. The profiling for physicians as well as hospitals, and of course your medical necessity, length of stay, and reimbursement. I always tell the doctors, I said, it's not about the, oh, you just want to get more money. I used to hear that all the time from the providers who I worked with in different healthcare organizations. I said, no, it's about high quality documentation. And then it improves care for that patient. And he didn't. I had this one conversation. I had a 45-minute conversation with the cardiologist in Cedars-Sinai, and I was supposed to be off the clock. And I was talking to him until like 4 o'clock in the afternoon. And he was like, "Nope." He goes, "I agree to disagree, Emery." I said, "Okay, doc." Well, after I moved to UCLA, one of my former colleagues reached out to me and says, "Hey, Dr. B, the cardiologist she had a conversation with a few months ago, now he understands what you mean, Emery." Like, wow, the light bulb went on. Sometimes that one little conversation, it could be even 2 or 5 minutes, doesn't matter. Sometimes the light bulb will click for that provider when you're discussing about diagnosis specificity.
I'm still waiting for that on one physician.
Yeah, well, it'll get there. It takes time.
It's an OB, and they just are really weird about it.
Right. Now, I forgot to mention down here, this is part of the value-based purchasing program, So when it comes to everybody's talks about, physician scorecards, quality data, that's your part of your value-based purchasing for the providers, right, on the outpatient side. So they can get an incentive of 1 to 2%. I think it may be 3%, or it can be negative 1 to 2 or 3%, where the Medicare CMS will hold back monies from that provider if they didn't do a really good job in maintaining that quality of care for their beneficiaries. And this is just the patient safety indicators, just some examples. We pulled this right out of the cms.gov website. You'll see the link down on the bottom, the address. And this is just something that it was from Battelle Cascade of Measures poster that they submitted to CMS, and CMS thought, well, this was really good. This is what basically the safety measures are when it comes to your PSIs. And they look at the 4 different goals. So you got 4 different programs, basically 4 different groups, and your reduction in national serious safety events. Of course, you never want to have a never event, like we used to call them, where a patient has surgery and then they die, or, they have a UTI and they were admitted for a UTI and then they die in ICU. You definitely want to keep an eye on that. It looks at your medication errors, EMR safety. You want to make sure you're following HIPAA. Also, your safety culture. There's no current measures there or workforce. They didn't put them in yet, but they're trying to give you some idea of what's going to be coming down the road. And then safety for a special population. So this is where your maternity patients, your elderly, geriatrics, they're definitely looking at certain goals for those patients while they're in the hospital setting. So I thought that was really an interesting piece to share with everybody. There's a lot of quality information out there, and especially in CMS. It's just a lot of maneuvering, a lot of research you got to do to get to where you want to be, unfortunately.
Yeah, and there's still a pretty significant maternal death rate too. That they're really with the OB. They're trying to work on her maternal deaths.
Right. Yeah, it should be a happy moment. That's for sure. Yeah. When it comes to documentation challenges, the old adage, if it's not documented, it didn't happen. So there is a gap between what physician documentation and what the coding language states. Providers take shortcut, right? Don't you love that copy paste in the electronic record? Not. And if they didn't change that around, if they're not changing their assessment and plan, CMS is also looking at that, believe it or not, that copy paste phenomena. They got involved with it after a lot of organizations went to the electronic record. So they're keeping an eye on that. And I know OIG had a facility they looked at. I don't remember where it was. It was back in 2016 or 2017, where they were looking at this facility regarding copy paste and how their electronic record was set up. I don't know if it was in the Midwest or up north. I don't remember. Not sure where, Northeast. But there was really some interesting stuff. So if you ever have time and you want to research a little bit, check out CMS with the copy paste, because they do have some items in there under their copy paste initiative they're looking at. And a lot of establishments don't realize the impact of documentation, when it comes to your diagnosis specificity. So, and documentation practices aren't really taught in medical residency programs. However, some schools have initiated some coding classes, believe it or not. One of the hospitalists that I work with said, I have a coding class about E&M. So they were getting some evaluation and management coding information if they started their own practice. He says, but I'm not opening my own practice. I'm just working as a hospitalist. So that was interesting to hear that. And it was nice to hear that, because I think the providers need to understand too, if they're going to be, they have to submit their E&M for their organization, who they work for, for their company. They better have an idea of what it's all about. That's for sure.
I just want to share, I had an interesting yesterday when I was in the office, because I'm working with the OBs to better their documentation. And I was working with one of our physicians, and she's a younger, just in that she's newer and had a little bit of stuff in school, but not a lot. But she came over because we're looking at on a generic diagnosis of hypertension, of getting some drop-down menus for the specificity of OB. And so I had a couple ideas for her, and I said, you know what, let's look at what the encoder sees. just so you guys know what we work with. And so I did a case, and she goes, wow, she goes, that's, like, that's not even here. We're not doing that anymore. I said, I know, but the encoder, hasn't removed it yet. Neither is CMS. And it was interesting. She goes, this is very interesting. She goes, this helps me because we don't see what you guys see. And she goes, the coding, often when you talk to us about it, she goes, it doesn't make sense. And I said, I agree. At 30 years of L&D, and it was an effort for me. But I said, I'm your liaison between the coders and the coding. And, this is what we see. It doesn't make sense. We have to decipher. And the coder doesn't have the experience that I have to decipher that chart, nor can they on certain things. This is why we needed you guys to bring it in. And she was very impressed with it. She goes, you know what? That makes sense why you're asking us these questions, because they don't have that labor and delivery experience to understand what that doctor's note means in relation to coding. And it was really a light bulb moment for her. And I was impressed with her because she's really been wanting to work with me on this. And I said, this is what I have to try to get across in the OB meeting. And she's helping me to be able to get that across to some of them that don't understand why I'm suddenly in this mix.
Yeah.
And it was very cool for her
to do
that, because she goes,
yeah, well, and that's the thing too, I always said about coding, you got to flip your brain around 360 degrees, because then it'll make sense, because it doesn't match clinical.
Yeah, because a failure to progress, that doesn't come up in coding. That comes up as a secondary uterine inertia. And even the doctor goes, what the hell is that? And I said, well, that's your failure to progress. She goes, oh my God. So it was very enlightening for her. And I was very happy for that, because that shows her what I'm trying to get across.
There you go. And even one provider, the light bulb turns on, boom. It's like, okay, we're getting somewhere.
You know what I find with the copy and paste is that I wait a couple days when a new one comes on, a new provider comes on, just to see. And if they keep copying and pasting, I'll query them, because, then they may change their mind and they may disagree, but at least I'm bringing up the topic that they've been cutting and pasting. Maybe that diagnosis is got a contamination, or maybe there's some other issue, and they're not truly looking at it. They're just trying to get their numbers done, and that's try to help them.
That's great. Good idea, Patricia. That's a great idea. Query the provider, absolutely.
Because sometimes they carry on, like on the assessment, rule out sepsis all the way. So, the third day it's still ruling out, and you have some, labs. So yeah, you're right, Patricia. You just query it and say, did you rule it out, or did you rule it in? So at least you have a more specific, that they're just copying and pasting if they do that.
And then I get excited when you've had a couple doctors document this diagnosis that is weak, and you're going to end up having to do a clinical validation. You're like, oh, come on. And then the new doctor comes on and removes it. I'm like, yes.
Yeah.
Well, I've said a lot of the physicians with validity, they'll say it's sepsis even though the sepsis criteria isn't there, or the respiratory failure, the patient's on room air. I don't know how they get that. There's no ABG.
Yeah.
I know, right?
Are you getting it?
Yeah, I've had that too. Some
Right?
respiratory failures and no O2 use at all. It's like,
That's like metabolic encephalopathy, acute metabolic encephalopathy. Patient alert and oriented times 3. The physical exam findings. Really? Yep. There we go.
Or that's documented on a patient with severe dementia, and I'm like, oh, those ones kill me.
And that's a challenge for CDSs, I think, when it comes to they have progressive dementia, or they really have acute
patients and restraints and everything, and they don't want to give you the correct diagnosis.
Right. That's true. Absolutely. Yeah.
Or they consider lethargy as encephalopathy.
Yeah.
Well, they're medicated with pain meds and they have some lethargy. Gee, I wonder why.
I know.
Yeah.
True. That's for sure. Okay. Like I said, they were having great discussions. Thank you for everybody jumping in. Let's talk about physician advisors or physician champions. So when it comes to the physician advisor, they're a physician or a healthcare provider who speaks on behalf of the CDI team, right? So physician buy-in is key when it comes to have a successful CDI program within the hospital setting. They can explain quality factors as it relates to diagnosis specificity. Your PA can capture, we want to capture high quality documentation within the hospitalized patients with follow-up in office settings that yields quality rewards. So that's a big piece of the pie. That's where your HCCs, your hierarchical condition categories come into play. Because if the doctors are specifying that information within the inpatient setting and then they say it's a community doc who admitted their patient, they're going to follow up with them in their office at post discharge. So they want to carry those diagnoses into their office chart as well. So that's your hierarchical condition categories at CMS, especially for Medicare recipients, right? Or Medicare Advantage recipients. They can get that additional quality incentive for their office setting. And then, of course, your quality documentation, data documentation leads to office setting reimbursement, which I just discussed. You always want to get feedback from the physicians too. A PA, you can have one PA for a small facility. You can have 10 PAs, different physician advisors in different areas of expertise. Because they're gonna speak to the CDI team. They're gonna talk to their peers, but they're also gonna discuss, okay, what are some of the challenges that the providers are facing from a CDI standpoint? Is it about queries? Is it a certain diagnosis they're looking for? What do we look for from querying for sepsis diagnosis? What are the clinical indicators we look for? Are they looking at the same clinical indicators, the clinical evidence in the record? So that's where a lot of feedback can occur between the PA and the providers in the hospital setting. And then they bring forth the value of the CDI programs to the physicians. Why are we so valuable for the CDI, for the hospital? It's not just about reimbursement, it's about quality data. And I tell all my docs, I said, it's about how sick the patient is in the hospital and is it the likelihood that they're going to die. So that's your SOI and your ROM data points that you want to really try to understand the diagnosis specificities relating to the data quality. So they could do one-on-one reviews with their peers. They could do clinical validation reviews. When we first started having clinical validation queries sent out, the providers were getting really upset because they thought we were questioning their judgment. It's like, no, we're just asking for further information if you can clarify this. When a lot of docs got really defensive with those. And unfortunately, that's because they felt challenged. Sometimes the physician advisor can jump in and help you with that situation. I know with one of the contracts I worked last year for Brundage, a provider called me. And he was an intensivist from the hospital. And he called me. And I said, please call me, And we were discussing it. And he goes, well, Miss Ann, I don't know about that. And I was like, well, you know what? Let's look at this. I said, do you have his record up? Because I'm looking at his chart. And this is what I see from my point of view, my perspective from a clinical documentation standpoint. And then he was looking back on his progress note. And he goes, oh, I see where you got that. That's part of my template. I was like, okay. I said, well, does he have that diagnosis or not? I said, because this is why I sent you that clinical validation query. I understand now. So what I should do is take that diagnosis off my template because this patient doesn't have this diagnosis. I said, okay, if you can remove it, that would be great. And then I wouldn't have to send a query for that diagnosis. And he goes, now I understand what you're asking. He goes, but it boiled down to their templates too with some of these providers. And it's like, you know what? You have the templates. Yeah, that's great for you. However, you better double check all your diagnosis you have under assessment and plan, because he had septic shock on there and the patient wasn't septic. That's why I sent the clinical validation. So, you know, you really got to take a look at everything. And I think the light bulb went on for that intensivist. He goes, "Oh yeah, that's part of my template." No, he doesn't have septic shock. He's hypovolemic because of his injuries. Yeah, he was an MVA patient, I believe. So anyway, so, you know, having that 2-minute conversation with him, he goes, "Can I call you?" I said, "Absolutely. Here's my number. Call me." You know, I'd rather have that 2-minute conversation with the providers, just to negate stuff so they don't get angry or defensive when it comes to clinical validation query reviews. And then also with the PA, you want to schedule regular meetings with the CDI team and our coding staff. You can review complex cases, which may lead to a clinical validation query. And then the provider can also educate the CDI team, you know, and the coders regarding pathophysiology relating to various healthcare topics. You know, there's a lot of new stuff out there today, modern stuff. I know they got a lot of new devices for heart failure patients, advanced heart failure patients. So, you know, it's really interesting to see how, you know, modern technology has definitely improved. Most of those cardiac devices are done on the outpatient side, though. Okay, but it's good to know to keep up with everything. And then, of course, the provider is going to get buy-in with the other hospital physicians to work with us, and then promote high quality documentation for each patient, and encourage physicians to utilize the high quality documentation elements, which are listed below within his or her office setting. I think it's really important to note when you're reviewing a record, you want to make sure that you have all these high quality documentations listed in every single note. Within the H&P, within your progress notes, discharge summary is one of the most important pieces, right, for a hospitalized patient, because we want to make sure that we capture the diagnosis in that discharge summary, because then they're confirming that that patient did have those specific diagnoses during the hospital stay. And just about thing about shell notes, you want to make sure you go according to your hospital policy when it comes to completing your medical record documentation. I know some facilities have your discharge summary doesn't have to be completed until you have 2 weeks to do it, which I think is really ludicrous. It should be completed within 48 to 72 hours, as far as I'm concerned, because the docs will forget some of that stuff. So you definitely keep an eye on your bylaws when it comes to your timeframes for completing certain documentation. Okay, queries. Got a query about queries. So clinical indicators, that's what we use, right? We use clinical indicators to review the queries. So the quality of clinical indicators, how well they relate to the condition being clarified, is more important than the quantity of clinical indicators. We also want to make sure that the clinical indicators we're listing for the provider, so he can give us the answer to the query, that it makes sense, it's appropriate. We also have, you know, your compliant query practices. You always have your multiple choice. You can use yes and no query responses. Usually we use those for present on admission status. You know, clinical evidence taken directly from the medical record, and provide clear, succinct indicators within the query. I always utilize the 3-legged stool. It doesn't have to be set up like bullet points. You know, your diagnosis, where was it documented, by whom, a diagnostic workup, treatment, but you can summarize it all within a query and keep it short, sweet, and to the point. I think it's really important that you don't need to write a book when it comes to writing a query. I think that's the goal. You know, I see a lot of other CDIs I worked with at the other contract company I worked with last year, a healthcare organization. They were copying and pasting the whole thing from the H&P, you know, the whole assessment and plan in there. And I was like, oh, that doesn't make sense to me. Why are you all doing that? Summary goes a long way, you know. But I think it's just, you know, if you're writing, you can do treatment and diagnosis at the same time based on what the provider's writing, you know. The doctor's writing sepsis without acute organ dysfunction, rather, with the clinical indicators listed of the tachycardia, the fever, the leukocytosis, and what they're treating with. So you got that information right in one sentence. That's great. You know, do you have to divide it out in the 3 bullet points? Not necessarily. You just want to make sure you capture all the items so you do have a compliant query that you're sending.
So my brother had a bad accident a year ago, and we got his chart for personal reasons. There was a query in there. I about died. It was 4 pages.
Wow. Yeah.
In his chart. I looked at that and I went, oh my God, our doctors would kick us out the door.
Oh, yeah. Yeah.
They don't have time to read. That's why you need to just,
I couldn't believe it. I was dumbfounded. I'm like, and it's a teaching hospital, so I don't know if that was the reason why, but 4 pages, I about died.
Yeah, I was like, okay. I think the biggest one I've ever done was a 2-page because it was a 21-day stay. And we had to clarify one diagnosis that was documented at the beginning of the stay, but then they dropped the diagnosis. Now, I'm sure you all see that. They can say, oh, it's probably sepsis, you know, blah, 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 unclear infectious source, workup in progress. And then 3 days later, no, the sepsis diagnosis is off. They just dropped it off. It disappeared out of thin air. And it's like, okay, guys, did you rule it out or rule it in? What's going on? You can't just drop it on us. So, you know, so that's the thing, too, you got to watch. But I think the longest query I ever done was that 2-pager for that 21-day stay because it was post-discharge. So it had to take, you know, you don't want to put a lot of information from the 21-day stay, but you got to put the pertinent information. So I did whittle it down to 2 pages for the hospitalist provider, and she did respond to it, and she clarified that particular diagnosis for us. I don't remember what it was, but yeah, it was a long stay. Okay, and then when to query, right? We all want to look at that 2022 AHIMA ACDIS practice brief update and when to query. Very self-explanatory here. You know, I'm not going to go through all that. I'm sure you're all aware of it because we all CDSs. We do what we do. And when not to query. I worked with this one company. They queried everything, including the kitchen sink. I was like, really? So to me, when I look at that, they query every little thing, even though you're at a max SOI and ROM of 4 and 4, they still query little stuff like hyponatremia. They'll still query hypokalemia. And I was like, really? I said, you're going to give the physician query fatigue, you know? But they wanted queries out there on every little thing. Is that appropriate? I don't know. Depends on, like I said, what your hospital policies are. I said, I think it's query fatigue you give the providers when you query every little thing. And then and then now they're going to get angry with you because you're querying on stuff that, you know, you got all the main diagnoses and you got everything listed within that record for that patient. And, you can see how sick that patient was in the hospital, especially if they passed away. Right. But, like I said, always go back to what your hospital policy is for queries.
And that's why the KPI. I'm sorry. Go ahead.
Oh, go ahead, Christy.
Yeah, that's why the KPI is very essential and important to be clear because some CDS they need to meet the KPI that's given to them. Like, what is your query rate? So if the query
And we're going to get into that.
well, yeah. So that's why the KPI is important to be accurate and clear. So that's what we're going to discuss after this.
And some of those too, when you're looking at everything, you want a clean record, right? You want the quality data there, and you want the coding to the nth degree, all the diagnosis specified to the nth degree for the coders. And I think when it comes to having your maximum diagnoses listed, your maximum SOI and ROM of 4 and 4, but when it comes to like a hack or a PSI, yeah, definitely you're going to clarify that, even though you're at a max, because definitely it'll give you further insight, and it'll prevent, hopefully, from reporting a hack, but you may have to. And that's why I see a lot of that. There's a lot of going back and forth, but Patricia, what you just mentioned, absolutely, you're gonna query for those, even though they're at a maximum DRG assignment and SOI and ROM level. But you want to clarify stuff like that, because you don't want to jeopardize the hospital in that respect either, even though that's why you need to clarify certain items.
And it's supportive of other diagnosis as well.
Right. Absolutely. Okay. CDI overview coding rules. These are just all the general coding guidelines that we all need to know, and then of course there's coding clinics out there to help. And then of course our PDX is what bought the bed, right? So if you have 2 diagnoses that meet the PDX definition, focus on the diagnosis that drives treatment. Your secondary diagnoses need to affect patient care, as listed down below. 2 or more interrelated conditions as the PDX. So if you have 2 or more interrelated conditions, meaning they're from the same MDC chapter and are meeting the definition of PDX, either condition may be used as the PDX unless coding rules apply. So sometimes you have chapter specific coding rules, right? So we may not be able to use one diagnosis. You have to use that second diagnosis that meets. And usually the coders are really good they're on top of their game when it comes to the coding rules. Combination codes, there's so many of them in ICD-10, as we know. It's documentation of cause and effect, and it classifies as 2 diagnoses, your manifestation and associated complications. I always, every time I see combination codes, I think of diabetes, because there's so many different aspects related, problems with diabetes, with different organs dysfunction. Codes for symptoms, signs, and ill-defined conditions. Do not want to use a sign or symptom code as the principal diagnosis, right? When you have a definitive diagnosis listed. The example, you syncope with complete heart block. Of course, the complete heart block would be the definitive diagnosis. Principal procedures, any procedure that's going to impact the stay, especially, when it comes to your fractures, and they go through surgery, that's definitely going to be your MSDRG assignment is going to be surgical instead of medical. And then certain procedures really don't change the DRG assignment, like your colonoscopy or your EGDs. Present on admission, this is one of the biggest pieces of the pie for CDIs. This is a key indicator to say what conditions were present and what occurred during the inpatient stay. But you also want to keep an eye on your hacks, which are excluded from SOI and ROM data, and also will affect reimbursement. Well, it'll drop it, right, as we know. Complications of surgery or medical care. Patient admitted for an infection post-surgery. Complication code would be listed as our PDX. And there's no time limits on complications, but you got to make sure that the documentation is linked to the complication of the procedure or surgery that was performed. Admission from outpatient surgery. Patients are directed admit to the hospital from a complication that occurred with an outpatient surgery. Of course, the complication is your PDX. Your uncertain diagnoses, possible, probable, suspected, likely, may be documented by the physician, and it can be coded as the diagnosis exists. But keep in mind, if you work outpatient, it doesn't apply to outpatient, it only applies to inpatient setting. And this is our coding procedures, procedural coding guidelines. They're all in CMS. It's like, I don't know how many thousands of pages. but there are indexes and tables to help the coder to assist. This is just an example of a lumbar spinal fusion. And we put in here. And now, metrics, key performance indicators. You cannot improve what you do not measure. I like that little concept. Isn't that the truth, right? All right, national benchmarks for CDI. Believe it or not, there are some common CDI metrics that you may see out there in just about all the healthcare organizations. Your CMI query rate, provider query response, and agreement rates within the inpatient setting. There's a metric-based model that's used to illustrate an expected course of a specific timeline for hospitalized patients. And that's where your best practices come into play too for the providers, when they're putting their thoughts down on that paper, and you want to make sure that they're spelling everything out for us. And then your healthcare executives really aren't in tune to the intricacies associated with CDI programs. Like we mentioned that if we don't have the senior leadership or the C-suite buy-in, that the CDI program may not survive. So really it's important to have the healthcare executives understand what CDI programs are all about and understand the metrics that we look at on a regular basis. There is an inpatient CDI metric model that begins with a perfect CMI based on complete provider documentation of the principal and all secondary diagnoses and maximization of your MCCC capture of diagnosis. That will also, as we know, maximize the MSDRG assignment for each hospitalized patient. So in the next slide, we're going to look at what the perfect CMI is. The CMI at the top, and then CMI before queries is at the bottom, and then an increase in CMI after queries have been sent, as well as an executive expectation line. Now, based upon this slide, there are national benchmarks for CDI metrics that may include hospital CMI and query rates. So when it comes to your national benchmarks, even though I read an article from ACDIS, I believe it was, and Cheryl Erickson, she said that there really isn't no national benchmark per se, but I did find an article that says, no, we do have an inpatient CDI metric model that we use that's considered national benchmarks for all healthcare organizations. So as you can see on this slide here, see how low your CMI is before queries? And your perfect CMI is where all the diagnoses are specified out and CDI doesn't send any queries whatsoever. Yeah, that's never going to happen, I don't think, in our world today, that's for sure. But then the CMI did increase after queries. This executive expectation line is just saying this is what the executives, the senior leadership sees. They want to see it hit as much the perfect CMI as possible, right? So from a CDI program standpoint, the metrics are key in looking at how well your CDI program is working in that particular facility. We query, yes, that's what we do. The CDI specialist will send queries or physician provider clarifications, whatever you want to discuss, in order to not only improve the CMI overall for the hospital, but also improve the quality of care for that patient. Okay, this is just one example. Like I said before, CMI, query rates, and provider response rates, those are some of the other topics that you're going to see, the other metrics that are used for CDI programs. I thought this gave a great little snapshot of what senior leadership thinks based on CMI, because we all know your CFO at that hospital is looking at that CMI, right? And they're looking at CDI. Well, why did it drop? Our CMI was 3.21 last month. Why did we go down to 2.9? Look it up. What's going on, right? And there's a lot of factors. And it's not just CMI that's part, it's not just the CDI program that's part of that CMI, right? We're a piece of the pie. And I think executive leadership needs to understand that component because there's a lot involved with your case mix index. So when it comes to best benchmarks and best practice for CDI metrics, benchmarks are usually derived from a pilot study, okay, performed by the CDI team. It's usually an average review time per review. There's service line based reviews, length of stay for each review, including creating that query, your provider education meetings, and any follow-up assessment of review rate goals. So an example on this would be initial reviews could be 8 to 10 charts per day. Subsequent reviews could be 10 to 15 charts per day. So your daily review rate or chart review rate would be anywhere from, 18 up to 25 per day, including both initials and subsequents. Best practice guidelines may be used by each facility based on national standards. Well, that's going back to your CMI, your query rates and agreement rates, okay? Most CDI programs do have your review rate, query rates, agreement rates. Sometimes they incorporate the CMI. They may also incorporate your MCC and CC capture rates, okay? And we're going to go through all that. Please note that not all best practice guidelines will fit into your hospital organizational structure, though. So each healthcare facility needs to have realistic benchmarks based on the type of facility and the patient population that you see within your organization. So let's talk about our KPIs, or key performance indicators. Your KPIs should be specific, time-bound, relevant, attainable, and measurable. Those are the keys. They got to be measurable, right? So when it comes to the definition of metrics, it's a measurement used to track, monitor, assess the success or failure of a business process, right? So as a CDI program, we're a business. We're in the business within the hospital setting. And we want to make sure that we have measurements in place to track, monitor, and assess. You know, are we doing a good job or we're not doing a good job? And what do we need to improve upon? So KPIs are metrics that are used by the CDI program initiatives, and they assist with the organization's strategic goals, support decision-making, and assist with focused education training. So that's a big piece of the pie. There's a lot of training involved. And when you're creating your metrics within your hospital organization for the CDI program, you have to look at the different parts of your hospital. You know, is it a teaching hospital? Do you have residents? Do you have nurse practitioners, advanced practitioners, PAs, med students? You know, is it a small community hospital? It's only a 100-bed hospital compared to a 400-bed facility. So you really got to look at what type of facility you're in. What are the hospital goals? What are the strategic goals? You know, what kind of training do we do in the hospital setting? Okay, so you have to keep an eye on exactly what program initiatives are in there within your setting in order to create your CDI program initiatives. Your KPIs are used to hire and or retain CDI specialists too, right? And are usually calculated on a monthly basis, right? Other organizations may tabulate their KPIs on a quarterly basis, a biannual basis, or even an annual basis. Some organizations will create a report that shows a year-over-year analysis. So they have it, they compile it, it's rolling, it's a rolling report. And they're giving you every 6 months or twice a year, or they give an annual. To identify new documentation opportunities with the providers, right? You know who stands out because you're going to trend your queries too, and we're going to get into that. And who needs assistance from a provider perspective for education. KPIs will vary between healthcare organizations, like I mentioned. Initial reviews can occur between 24 and 48 hours at the time of admission. Other hospitals may perform initial reviews within the first 24 hours. Once that admission order is written, that that case is dumped into, that chart is dumped into the CDI program, right? Into your software program for initial review, your dashboard. So will there be any medical record or documentation information? Maybe not. Maybe not. So so you definitely want to keep an eye on that. And when you do start your initial reviews, the time frames are important, I believe. Organizations may have internal as well as external KPIs. So your external KPIs are usually your severity of illness, your risk of mortality, and your quality measures. That's where your PEPA report and your MedPAR data come into play. Whereas your internal KPIs focus on the mission and objectives of the CDI program within the healthcare organization. So, types of key performance indicators. Your medical record review rate, like we discussed, what is that? The number of charts reviewed by each CDI specialist. Your initial reviews, they take a little longer to review, right? Because you're putting the pieces of the puzzle together to obtain a clear picture for the patient's hospital admission. I always say initial review, what bought the bed? This is where the CDI specialist is going to build that case. You're going to play detective and you're going to build that case to say, okay, what diagnoses are going on? What's the acute problem for this patient? Your subsequent reviews, this is where additional information within the record is reviewed. And this is where most of the time your query opportunities are found in your subsequent reviews. Especially if you're looking at a patient who just came in the door, say they came in, they were admitted, and they've been in the hospital for like 32 hours, not even 48 yet. So they're just starting the workup for that patient, right? Once you have further information to create that compliant query, that's where your subsequent reviews come into play. And I've always said that if you don't have subsequent reviews, you're missing a lot of query opportunities. One contract I worked briefly, they didn't do subsequent reviews. And I was like, okay. I said, they only did initial reviews. And then they would only review it based on the way their CDI dashboard was. If it came back, there was additional information, if they had a surgery or a procedure of some sort, then it would pop back up on the CDI list, work queue list. And if you review that, you'll see your name, and then you would go back into that case. You never assigned a subsequent follow-up review date, which was, like I said, is very strange to me. I've been doing CDI for a long time. I was like, oh, okay, if it pops up on the list, then you review it because there's additional documentation in the record. Okay. So do you all have subsequent reviews in your programs?
Yes, ma'am, we do.
Okay.
Yes, we do, but they're hard to get to right now.
Yes, we do.
Yeah, well, you do too? Okay, good. Good to hear that. I like hearing that because I was like, yeah, that threw me off a little bit from a CDI point of view. Okay. Another type is your provider response rate, and this is where your percentage of responses from the providers within a specified time frame that is set by your facility policy. So you want to know what your facility policy is for that, as well as your provider query agreement rate, measures the frequency. Does your provider agree with the specified diagnosis, your diagnosis specificity? And then some facilities will also capture unable to determine or disagree rates. So you want to see exactly what your policy states. Query rates are another big thing. This is where the number of queries sent to the providers compared to the number of chart reviews. Just keep in mind, if you do query rates, that, once the providers learn certain things, even though you get new ones, like if you're in a hospital, teaching facility, you get new residents. So of course your query rate's going to be up again. But your query rate usually will drop over a period of time when the providers learn. When CDIs educate the providers, your query rate may not always be high. It'll drop. I believe ACDIS and AHIMA, they said their standard was around, I think it was above 15%. Usually I see them around 20 to 25% for facilities. Do you all know what your query rates are? Are you measuring that in your metrics?
30%.
You're 30%. Okay.
Yes.
That's
We have a rate, but I don't know what ours is at Henry Mayo right now. I don't remember.
yeah, okay. Patricia, do you have one?
I don't remember what our rate is. And
Ways?
I
Okay.
don't remember what my rate is because we get it monthly, but I don't really, I look at the numbers and I don't memorize them.
Yeah, I know what you mean. Yeah. Well, the current company I work for, the contract company, they're a 40% query rate.
Holy criminy, I thought UCLA was bad.
Right. They're 40 to 45%.
Wow.
Yeah. So that's like you're sending like 2 or 3 queries per chart
That's
if you're
a question.
doing 15 reviews.
Are you querying in mortality variables or just specificities, or how do you get?
Everything. Everything. Yeah. That's why I'm saying sometimes when I look at query rates, like when they're that high, I think to myself, trash in, trash out.
Yes.
So you query everything. And then when they told me when I was going through training with them the beginning of the week, and I was doing reviews, right? And they said, our query rate is 40. I said, well, the director told me that it was 45. She goes, don't let that freak you out. I was like, yeah, no. And I told my contact over there, her name was Amy, and I said, Amy, I tell you, Amy, I usually hit about 20 to 25%. That's the norm for the most part for me. I said, I could push it to 35, but I don't want to query just to query. And she says, and we don't want you to do that either, Anne-Marie. I said, okay. I said, and that's why I mean by trash in, trash out. You're going to query every little thing. Like that other company I worked for last year, other contract company, they queried everything. And to me, that definitely will give the providers query fatigue or query weary, as I call it. So you definitely want to keep an eye on that.
That's
Absolutely.
ridiculous, and that it shouldn't be that high.
40%. I was like, okay. I said, I'll tell you right now, I won't hit it. And they all started laughing. I mean, because it's like, is that really realistic? For the healthcare facility you're in. Yes, it's a teaching facility, and they have like 5 different facilities with this organization I'm working for on the East Coast. But you know what? I was like, come on. You got to make it a little realistic here. I don't know what their benchmarks were. But it'll be interesting to see what occurs over the next couple months. Another type of KPI is MCC and CC capture rate, and these are, of course, your secondary diagnosis that will give the hospital financial impact. Your SOI and ROM data, of course, usually dependent upon your MCC or CC captures, but also your non-CCs. Some of your electrolyte imbalances, like your hypokalemia, hyper or hypocalcemia. They're not CC captures, but they will definitely impact your SOI data or your risk of mortality. Your provider disagreement rate, that's why I said some facilities will monitor that to see if they agree, the provider disagrees. Your CMI, of course, that's your average of all MSDRG relative weights for hospital inpatients within a specific specified time frame for a specific patient population. Now, you a CMI with Medicare recipients, Medicaid, or even commercial payers, doesn't matter. You could do it based on what reporting system you have within your facility. You'll be able to capture that information. Denial rates, too, may be shared. This is where the percentage of claims being denied by payers within a specific time frame. And then your MSDRG reconciliation rates. Some facilities will include that in within the CDI program. And this is where your percentage of charts resolved by the CDI specialist to determine if CDI and the final coding DRG assignment matches, right? I haven't seen that per se within the metrics themselves in all the different organizations I worked, but it could be. You never know.
Now we
Yeah,
do
the
that
previous,
where we do the matching of the coder and the CDIS. And there are certain areas that I do pretty good, but there are certain areas that I stink, and my batting average is horrible. And that's when you have two diagnoses coming in at the same time. And I always seem to choose the wrong one, but I choose the one that's also getting treated.
yeah.
Right.
Mm-hmm. It's like in the
And you know,
previous facility I worked, they have what do you call this? A specific person, and they call it mismatch diagnosis. So that's when the CDI is reviewing it because it doesn't match the coder's final coding. So they do have that in some facilities, like the mismatch. So,
And I forgot to say that the coders, some of our coders are very nice where they'll tell me where I made my mistake and how I can improve, which I love because that'll help me the next time.
mm-hmm.
right, absolutely. And you know, a big piece too. I'm sorry, Christy, just before I forget again, a
Mm-hmm.
big piece when it comes to your DRG mismatches, and when you're looking at that record concurrently, if you have two diagnoses that really meet that PDX definition, look at and the treatment that's performed, and they're treating them both the same. Look at what the geometric mean length of stay and what the possible reimbursement is. Because what the coders will do is they'll go to the higher reimbursement DRG assignment.
And
Just
the longer
FYI.
stay sometimes because that'll help account for why they might still be there.
Mm-hmm.
Correct. So they'll
Mm-hmm.
look at that. They'll look at the geometric mean length of stay as well as the your not just so much your SOI and ROM data, but also the reimbursement is a little higher than the other diagnosis. Hit the money, right? And that's what it is sometimes too, you know.
And if they're
Yeah.
not treated equal, like I've had that, and they'll say, but this is higher reimbursement. And I'm like, okay, which one did they treat more? We have a UTI here with some serious antibiotics, and we got, you know, an AKI that's iffy, you know, and I'm like, you know what? We need to go with the UTI because, you know, you got ID on board, you've got 3 different antibiotics on the case, you know, the AKI is minimal, like it meets, and they're given like a liter of fluids, but are they really with only 1 liter of fluids treating the AKI? So I tend to kind of go back and forth, and sometimes I win and sometimes I win.
Yeah.
Yeah. They
But we
always win.
speak, yeah. Well, we speak our, you know, we give them the objective data that we review from the clinical standpoint. And sometimes, you know, they're still going to go, if they're going to go with the higher DRG assignment and it was minimally treated compared to the other diagnosis, then, you know, they have the coders have the final say. Their name is on that claim form. So, you know, we just chalk it up to say, okay, we agree to disagree and we move on. Right. And I've had that encounters with numerous coders in all my career. And I've been doing CDI. And we, you know, we just agree to disagree.
And I do make a note on my chart about that as well, what I think is the primary, you know, just a little note in my notes, because for instance, my facility at our monthly meetings, my supervisor shares denials. And say one comes back and it's mine, and you know, like we're fighting it, you know, she lets us and, you know, the coder know, and I'm like, okay, look, I was overruled. You know, the coder has the fine, and if I really feel strongly about it, then I send it to my supervisor and the coding supervisor. But I make sure to have a little note so that I'm not dinged per se.
Yeah, and that's a good thing about giving it to the supervisor, because that's also what we do in the facility I used to work. Is that if you know, the person doing the mismatch strongly agrees and all the clear indicators are there. So she's just going to escalate it to the supervisor, and the supervisor of CDI and supervisor of coding will be discussing this. So, but at least, you did your
Yeah.
the due diligence on that one.
Yeah, I just had to do one for a POA status because the doctors were clearly documenting that two things occurred after the patient was in the bed and being worked up for chest pain. Patient aspirated with respiratory failure, and it's clearly that the doctors are documenting not POA. But the admit
Mhm.
order was the same. The inpatient admission order was the same day. So the coder's impression was that because of that, it was POA, and it's like, and my coding supervisor agreed with me.
Mhm.
Yeah.
And I'm
So
like,
Patricia and Kim, do you all have escalation policies in place?
We do, but it's very loose.
Mhm.
No.
Mhm.
Okay.
In the future, it's going to improve with our merge with Bellstar, so it'll be better.
Yeah, okay, the only way is up, that's for sure.
So for our facility, we
Patricia?
actually have our managers, and what they'll do is secondary reviews on some of the mismatches, and they will email,
Okay.
CC me and email the coder, and they will say, hey, I think it's this way, and they'll give the definitive information in regards to why they think it's that way. And they'll also do it
Okay.
for certain query opportunities that maybe I missed because the doctor did it on a discharge summary and I wasn't able to see it, which is can be apparent sometimes.
Absolutely. Absolutely. And we don't see the discharge summary most times. We're doing concurrent reviews. So it's subsequent documentation. And I think a lot of CDI supervisors, management team, they need to understand that we're not seeing that, it's subsequent documentation. So they really shouldn't be dinging us in that respect, right? You shouldn't, that's not an educational opportunity. It's just subsequent documentation. And that's what it should be listed as such when you're looking at your DRG mismatches too. Okay.
Yeah. Yeah, and also before, when I first started CDI, the coders were really basing everything, the diagnosis, on the discharge summary. So sometimes the doctor will not carry it over to the discharge summary, but it's clearly treated, but it's just not the diagnosis. So they will base their coding on just on the discharge summary. So I think they have already changed that position at the first facility I worked for, because you have to see the totality of the chart or the patient's condition
Right.
rather than just the discharge summary. So.
and if they carry
Yeah.
it through, I always look at the last progress note before the discharge
Mhm.
summary. I feel sometimes those discharge summaries don't have everything. And I
Yeah.
look at the last progress note, and if it's still there, to me, it's codable.
Yes. Mhm.
Absolutely. Yeah. Okay. Very good. Okay, so these are a couple facilities that I found some information on. This was in, I believe I found this article in ACDIS website, and they said that this was Brigham and Women's Hospital, and they do all payer reviews. So their chart review rate was 90% as their goals. Query review rate was 15% financial and 45% quality, which I found interesting. The provider response rate is 95%. Provider agreement rate was 80%, but they also added in unable to determine rate. Now, I found that interesting because I haven't seen any facilities do an unable to determine rate unless it's done on the back end. And it's under the management team is looking at that, and it's at a higher level, so it could be part of the escalation process. So I thought that was really interesting that they have an unable to determine rate in theirs. This was another anonymous hospital that they have quite a few facilities. I don't know how many, I think maybe 15 or 20 or something. And their chart review rate, they wanted 100%. Query rate was 90, provider agreement rate 90, and their disagreement was 2 to 5%. So they gave a little leeway for disagreement rate on their goal. Now, Ascension Health also did all payer reviews, and the chart review rate was 85%. That was their goal. Query rate was 25%. So that was both financial and quality. And then they looked at their physician agreement rate, and that was 80% or higher. So they did all meet their goals from reading the article. Each of the senior leadership, the directors, the CDI directors, did mention that, yeah, we met our goals. We're above our goals. That's why Brigham and Women's Hospital, their chart review rate went up to 90%, because they had their initial program, they had a chart review rate of 40%. So they did some changes. They had a vendor come in and say, help us streamline some stuff. And then, of course, they got the CDI program to help their CDSs make it easier to do reviews and increase. And then, of course, all the electronic medical records that are out there. So that's why their chart review rate went up above 90%. They were hitting about I think in 2022, the CDI director said that they hit 96% chart review rate for their facility, which is, that's phenomenal.
Okay, time out. So this anonymous hospital wanted a 90% queries done?
90%. Yep. That they're going to hit over 90%.
Holy moly. Glad I don't work there.
Right. Now, see, that's what I'm saying. Look at the query rate for Brigham Young. They divided out their financial and quality. Their quality, they want 45% queries. So they want more quality queries sent than financial, because they're not going to, they feel that financially, 15%, that's good, but 45% quality. Because what are they looking at from a quality perspective? They're looking at hacks, PSIs, all your quality initiatives that are out there today.
Wow.
So, yeah. So I found that really interesting. But you notice they don't have a disagreement, but the anonymous hospital did. And then the physician agreement, they didn't have that listed. So I think disagreement rates, yeah, you're going to have some. You're going to get some disagreements, guys. Nobody, the provider, they're the expert, right?
Yeah.
They may not disagree. They're going to write something else in there. Or they just totally disagree with your diagnosis, and that's fine, but having a range, less than 5% disagreement rate, I think that's appropriate. You're not going to get everybody on the same page. We all know that, right? Especially in healthcare.
That's for sure.
So I thought this was just some interesting examples on what, KPIs, what different facilities are doing out there in the United States here.
So for my facility, we have some doctors that are a little less responsive, timely responsive to queries. So the facility has set up where they get suspended over a certain amount of time. And that seems to encourage them to answer queries. Now, whether that means that you're going to have a doctor that's going to answer or going to disagree, or is just going to disagree with everything, that's totally up to what they do. But we have had our managers had to talk to some of the doctors that disagree with everything, because there are very valid queries like pressure ulcer and other things that they need to bring up, because those are significant to the hospital regarding the quality and everything else. But
absolutely,
one hospital that has that 5 to whatever %, I want to know what they're doing with MMDs, because let me tell you, that's pretty impressive, and it's hard with certain groups.
That's right.
If you've got certain groups
I'm telling you,
that don't play the cards, how are you going to get them to do it?
Yeah.
Right.
In the facility I used to work, I think it's in Memorial, Anne-Marie. It's like the medical records, if your query was not responded within 48 hours, the doctor will be suspended.
Whew.
So, they did.
Ours is 30 days, and they'll be suspended, which is because ours rotate, and you might get them at the end of a rotation. It could even say it's 2 days, and they are just so busy they can't get to it. So that would really ding them. But ours is 30 days, which I think 30 days is too long. I think it should be 2
Yeah,
weeks.
it is because you have to close the case. So if you're gonna wait for 30 days, I mean, so
Exactly.
if I'm not mistaken, probably 2 3 days. They need to answer the query post discharge because the case will be closed on the CDI part. So well, the medical director agreed to it, so they get suspended if that query was not responded to. So.
Wow.
Right.
Mhm.
Yeah. And that's the thing too. And I think sometimes when you see that providers, Patricia, do you have a lot of community physicians that work in your hospital? I don't know if she's there.
Are you talking to
I'm
me?
sorry, can you repeat?
Yeah, Patricia. Well, even Kim, you can answer this. Patricia, do you have a lot of community providers
We have
within
a
your
lot
hospital?
of different providers, residents, and some are different groups from community. But what I always say is that for residents, especially if they start coming up with, not answering and everything, my whole thought is who taught them, because they're learning from their mentor and what he's
Mhm.
what
That's
he's
right.
doing.
That's
And
right. Yeah.
my whole thought is all that these residents and these students who they're learning from is going to determine how they're going to be answering and working with you, because that's where they get their that's where they get their whole
Instruction.
mindset.
Mm-hmm. Yeah.
Right.
Yeah.
Okay. Kim, what about you? Do you have a lot of community docs or just mainly the hospitalist teams?
Just hospitalist. Well,
Okay.
all services.
That's
no
nice.
community based. No
Yeah.
community
Hospitals
based.
is a
Facility, teaching facility.
Yeah, you're
Mhm.
teaching. So
So we have
you
every
got a lot.
service for trauma
Okay.
center, pediatrics, the whole thing. Yeah.
So you got trauma, you got other community docs that come into your facility as well then, I'm
No.
sure.
It's all for, it's a medical school teaching facility. So each service has attending physicians. We do have hospitalists, but they're hired from
Okay.
hospital, if that makes sense.
Uh-huh.
Right, you're right, correct. Okay. So you got your academics. So you have your attending providers are your academic faculty docs.
Correct.
Yeah.
Yeah. Okay. All right. Okay, so this is just an example of a senior leadership review from a CDI standpoint with the metrics, the KPIs. So it's a high-level performance review. So this particular facility, the metrics that they show their senior leadership is your CMI, your Medicare and your Medicare managed, your MCC capture rates, and then physician response rates, all payers. So they're looking at everything. So for January, February, and March, you can see the CMI did go up and it stayed the same between February and March. The CCMCC capture rate went up in February, but dropped a little bit in March. And the physician, they want to know the physician response rate at this facility. I was wondering, I was thinking to myself, why do they want to know the physician response rate? Right? It's probably a hospitalist group. And that's why they wanted the physician response rate to see what they were, if they were they were responding to the queries quickly based on their time frames, and their policy. So it's probably a hospitalist team for this particular hospital, inpatient hospital. And they looked at the volumes, and there was a 2.1% increase in total volume. So medical volume decreased by 0.2%, where surgical volume increased by 11%. So that's why you saw that big bump in the CMI from 2.05 to 2.1. Surgical cases were there. Overall CMI was 2.1, virtually the same as last month. That's a little typo with the 6 in there. And then the capture rate was 79.31% for Medicare. So you can see that's a little low, but the volumes changed. And their queries were 98.2% response rate to queries. So we're going to look at slide 12 for more details. But I thought that that was interesting to see from a high level and what your CDI directors, your managers, what they are reporting to senior leadership when it comes to CDI metrics, your KPIs. This was a fiscal year 2024, the hospital CDI metric example. This was an annual report. Okay. So this community hospital was about 300 beds, 4 CDIs. And you can see that they had the CCMCC capture rate on top, severity of illness. They did risk of mortality data. So they caught all that. Of course, your production, the chart reviews that were done. The CDI physician activity, as you can see that it was broken down. The physician response rate, the main goal, it was greater than or equal to 95%. They were getting 100% response rates, which was great because they had buy-in with all the providers at that facility, right? And then they broke it down into the responses or in process, no responses, and then average days to sign. That's one of the medical teams there, hospitalist teams. And where they were at, okay? They also broke down the agreement rates and then the disagreement rate with the no responses and unable to determine. They were looking at less than 5%. So I think that's a pretty decent metric, benchmark when it comes to disagree, no response, or unable to determine. They also looked at your CDI queries. What was the total queries that were placed? So they're looking at greater than 15% query rate, okay? In the red, you can see under your production and under your queries, it's below the benchmark. And then they also had the financial and the quality impacting queries spelled out for you every month. And then they would give you the dollar amount. So they would share this with senior leadership. They would share this information because the CFO, of course, wanted to know what that financial impact's going to be. How much money did we make for them? Okay, based on what we sent for financial queries. So you can have, this is like a running annual total report, okay? You can have that. You can have monthlies. You can have a variety of ways that they can report out the metrics. Okay, great. Okay, and this is another hospital. This is part of a larger organization. They have about 10 CDIs in 3 facilities. And this is their monthly CDI metric. This was for each CDI. They had it spelled out. So they did, the new reviews for number 1 CDI and, all their CDI specialists are listed. Of course, they're blocked out, but they had 1, 2, 4, 6, 8, 10 of them. And then if they were in the yellow, they were like, okay, you're close, but you're not there at that metric yet, that benchmark yet. So they're getting there. The pink, they were lower than the benchmark, so they got to improve that. As you can see, there were some pinks for initials and continued stays, so they looked at that. Their response rates from the queries, okay. And if there were any second level CDI reviews, you can see on the bottom, the 9th CDS, she had 206. So she had to do a lot of CDI reviews. She's probably a lead that's doing second level CDI reviews for maybe for denials or something. So she's looking at those cases. So she did quite a few reviews for those cases. And then continued stay. So I think it's, like I said, and then the hours work they even put in here for their CDSs. And I believe this particular one I received from a friend of mine. She said to a former colleague, she says that they all work remote. They do not work in the hospital. The only people that are in the hospital is the CDI educator, the physician advisor, and then the management team. The managers will go in 2 or 3 times a week, where the educator is there on a daily basis. to work with the providers to do education. They have a specific CDI person assigned as the educator at their facilities. So they have 3 different educators at their hospitals. So it's really interesting to see how different facilities have different metrics, right? And that's the key here. That's what I'm trying to bring all this data to show you that, yeah, there's a comparison of monthly metrics within a healthcare facility. So these were monthly, and they looked at the number of queries, number of cases with queries, the percentage of cases with queries, query response, and query agreement rate. So they looked at a 3-month period. So they looked at it quarterly at this particular facility. The number of cases with queries, as you can see, it's in the yellow. I don't know exactly what their benchmark was, so they probably wanted it a little higher because it's not in the green. Okay. They had 331 queries for the month of March.
Wow.
In the second, wow, yeah, right. Look at the third quarter. They had 1,500 queries, 1,600, January, February, and March. And the response rates by the provider were pretty good. But they were still only hitting like 27% query rates, you know. And those were from a 2-day stay. So look how many queries they did. And these were from 2-day stays. Could you imagine? You're querying every little thing in that record for 2 days.
That's nuts.
Yeah, I'm telling you. Crazy. But anyway, I thought that was pretty interesting too.
Yeah, I think this one is, I think I'm familiar with this. Well, this is the 25% of cases with queries. And the 2-day stay, there's about 18 CDS. So that's why you could see the number. It's just the total of all the 18
Right.
CDS, that's what they're doing. And
Same.
yeah.
Yeah, but that's, yeah.
With that many CDIS, you've got a lot of patients, so your numbers are going to be higher.
Yeah, that's productivity is 25 per day. So if there's 25 times, 18 people, so I think that's why it's you could see that a large number. There's no productivity, but the queries, yeah.
Right. A lot of queries sent, yeah.
Mm-hmm,
Which makes sense.
mm-hmm.
You're in a healthcare facility. HMO companies out there, yeah, that have not just guys and they have their facilities. So yeah, you're going to be sending a lot of queries, especially with 2-day stays.
Yeah, and that's what it is a problem because, if you have a benchmark, so these people, I mean, we are sending queries just to meet that benchmark. So,
Okay, I'm there.
Yeah. So as you can see, these are spine surgery hospitals, different specialist hospitals for general and orthopedic surgery, as well as heart surgeries. So I thought that was a nice little slide to give you an idea of see how the CMI does pick up. Can go really high when it's a surgical hospital. It's not so much medical as it is surgical, which is great. Okay, chart review metrics. So chart reviews vary between different healthcare organizations. So it's the computation of number of charts reviewed by each clinical documentation specialist, the CDIS, divided by the number of health records assigned for review within a defined time period. So for example, a CDS is meeting the goal without any problem. One may wonder if the chart review goal should be increased since the CDI team is only reviewing 50% of the admitted patients. Okay, so if they're meeting that low goal, you want to increase it. However, if none of the CDI team is meeting the daily chart review goal, then the manager or director may need to rethink that goal, right? And or hire additional staff members. Variables such as weekly or monthly meetings, your provider education, and other responsibilities, like doing your DRG reconciliations, your recons, or computer issues, what day of the week it may be, they all play a role in the chart review metric. Another example here, the CDS needs to attend an online 2-hour seminar. Well, if the chart review metric is 25 charts per day, the CDS should be reviewing 3 to 4 charts per hour. However, with the 2-hour webinar, the total chart review metric will only be 16 or 17 charts for that particular day. So you got to account for variables when you're setting up your benchmarks for your KPIs. Your provider response metric, the percentage of provider responses within a specific time frame as set by the facility CDI policies and procedures. Always go back to your facility policy, like I keep mentioning. This metric also can measure how the providers are engaged with the program. You know, hey, they're responding. This is good. Okay, they're understanding us. You know, that's good. So maybe we can get more education going with them. So all provider responses are usually captured by the program in a software tool, all right, that's utilized within each facility. One example is your 3M360. I've worked with that one. I've worked with Midas. I've worked with Meditech, Thrive, variety of stuff.
Failure to thrive.
Failure to thrive, I know. Your agree, disagree, unable to be determined, and other. These are what, you know, we're looking at for responses. Additionally, some facilities will further dissect the provider responses to the queries, okay? If the same choice is always taken, like unable to determine, or they disagree with all of them, like one of the, we were all discussing earlier, and not responding at all. Usually these provider responses are escalated to the physician advisor for peer-to-peer review based on the facility I worked at. That was the escalation process. Now, your agreement metric is the calculation of number of times the provider agrees with the query recommendation and documents that diagnosis within the record. This metric goes hands in hand, of course, with your response rate, right? So some facilities may have defined timeframes for query responses. And this is usually monitored by the CDI team or the programs, the software program that's being utilized for the CDS team. Some facilities will provide the provider response that's listed within the query choice, and other facilities may not. So in other words, if the provider documents unable to clinically determine on a query sent for acute blood loss anemia, the facility policy may list this response as a disagree based on the policy and procedure for that query response. So if they disagree with a particular response, then it's going to be a disagree under the disagree metric. If they write something else, say they write under other, they give you another type of anemia, that may be considered an agree response. But again, it goes back to what the hospital policy, what the facility policy is for CDI queries. So keep in mind that the provider is reviewing the CDS query in the medical record to choose the best option based on the provider's clinical expertise and judgment. I think a lot of people, it's like they're the expert. They need to let us know.
And
Now,
there were some
the
patient.
Well, that's it. And there are some hospitalists out there that, are they really good? You know, you question, right? Especially residents, they're learning. So you definitely have to engage a little more with the different hospitalist teams if they are new to becoming a physician. Okay. And the disagreement metric, this is a calculation that measures the number of times the provider disagrees with the clarification. Some facilities may rate a specific diagnosis listed by the provider and not the actual diagnosis the CDS was hoping to receive from sending the query. Again, the acute blood loss anemia query was sent to the provider, but then he wrote anemia of chronic disease. So it could be listed as a disagree or it could be listed as an agree. So that's why I'm saying it's very, you got to really know what your query policy is and what it states when it comes to measuring your query responses.
See, to me, if they give me something like that, I consider it an agree because they're not saying it's not there.
Right. But like I said, that you got to look at what your policy states.
Yeah.
Because if they don't give you the answer you want, Most facilities will say that's going to be a disagree.
Oh, okay.
Even though they wrote something similar, you're still asking for anemia specificity, and they gave you a different type of anemia. I would consider that an agree too. However, some facilities say no, it's still a disagree because you didn't get that obla you wanted.
Okay.
Okay. So that's why it's really important to know what your query policy is at your facilities. Now, our query metric, this is the number of queries sent to the provider compared to the number of chart reviews that was performed by the CDS. So a chart review is 25 charts per day, and the query metric is 25%. So a CDS is expected to send 6 or 7 queries per day to meet the query metric expectation.
Ugh.
That's just an example, okay? Query rates can be viewed in 2 ways. A decreased query rate may indicate that the provider is engaged with the CDI program and is providing diagnosis specificity for all the diagnosis for that patient. Or the CDS is not performing a thorough review of the chart. The manager or director will perform a random audit of the CDS's reviews to see why the query rate percentage dropped. Please keep in mind that new coding guidelines and our quality of care may change the query rate too. So you have to look at, you can't just look at a query rate and say, no, you need to meet that. That's like that 40% at my current contract company. I was like, you know what, I'll never meet that. I can get up to 35% depending on what type of chart I'm reviewing, right?
Mm-hmm.
If I'm reviewing regular med surge charts and not critical care or trauma cases, I may not get that query rate even to 20%, okay? So you have to look at what types of charts you're reviewing, what is going on, how engaged are the providers that you're in the organization you work for. Okay. And is that a really realistic goal percentage for that KPI, for that CDI team KPI metric? I don't know. Some facilities don't measure the query metric or query rates because it may produce poor quality metrics. Because poor quality queries are being sent out. That's what I mean by trash in, trash out. You're sending queries just to query, which you don't want to do. You got to do it from a quality perspective standpoint and compliant. Some facilities may review the types of queries sent to providers to drill down to your potential educational opportunities for the providers. You know, if you're sending a lot of heart failures specificity for type, then maybe a little education, 5-minute education with the provider team. You know, if it's your hospitalist team or say it's your cardiologist group, maybe you have a 10-minute conversation with, set up a quick meeting with them on Teams and say, hey, you guys are really doing good with the acuity and you're putting the severity in, but we really need the type of heart failure. If you could document that for us, that'd be great. So, those are the little things that 5-10-minute conversations or a quick team meeting, 10-15-minute Teams meeting goes a long way. And then, of course, you're unable to determine metric. The provider is unable to determine if the diagnosis has been ruled in, ruled out, present on admission, or not POA. This is where your provider's clinical judgment and expertise comes into play. Even though the clinical indicators that we put on that query may support the rule in, rule out, or present on admission choices, based upon the clinical evidence in the record, the provider has the last say to determine the diagnosis in question. Sometimes the doctors, a couple of hospitals I worked, I sent them a query for, if sepsis was present on admission. And it looked like it was present with the clinical indicators, the evidence in the record that did support, your sepsis. You have your SIRS plus infectious source. And the doc couldn't really say, well, it's hard to say. Because they did have leukocytosis, they had a fever coming in, they were a little hypotensive. We knew they had pneumonia, bacterial pneumonia, but then they ended up getting worse. They crashed and they went into septic shock. So he says, it could be present on admission, but I'm really not sure. But the septic shock didn't occur until during the stay. So, so that's where you have your iffy. So that's why you really want to leave it up to your provider to clarify that for you. And if they say they're not sure if it's present on admission or not, then you know what? That's okay. They're doing the best they can with the information they have. No response. Well, that's really self-explanatory. They're not responding. They're not even looking at the queries that we sent them. And some instances, providers can bypass the response section within the electronic record by just clicking a button, and then it goes off their work list. So just out of their inbox or whatever, in basket. And so just be aware of that. And again, it always goes back to your policy for escalation processes. Okay.
And Marie, quick question. So
Yeah.
when you were just talking about that sepsis, so I actually have one that I just reviewed it on Thursday or Friday. It's sepsis, coming in, they've documented that. And they documented severe sepsis. And I think the patient had AKI. They had something that qualified for that. But there wasn't shock initially. And then it was like 3 or 4 days later, that patient crashed and was transferred back to ICU and on a level fed drip with shock, but had the severe sepsis coming in, met the organ dysfunction. So I have that as POA, yes, but essentially the shock is not.
Right, correct. Because it occurred during the stay.
So that severe sepsis with septic shock should be and not POA.
See, that's the other thing too. You have severe sepsis on admit, but they weren't in shock.
Right. Till it was 3 or 4 days later.
Yeah, see, and usually what's the rule of thumb, most of the coders go by according to, within 48 hours, right?
Right.
Is the POA status.
I think
Yeah.
I think the severe sepsis, when you have shock, it defaults to severe sepsis. So I think even though it's not present on admission, it still defaults to severe sepsis, if I'm not mistaken.
Well, it does, because we had the organ dysfunction, so we
Right.
met severe
That's
sepsis
right, yes.
away.
Uh-huh.
But the
Yeah.
shock
But the
wasn't.
patient didn't have shock coming in the door.
Yeah. But
Well,
I
if
know
you-
that
if
I
you-
had been taught if they had the severe sepsis coming in and met that and then developed shock, it would
Shock.
continue with the POA status going forward because the severe sepsis was there. But it just,
And
that
see-
one seems awkward to do.
Yeah.
Right. And you know what? That's where your coding supervisor reach out to Yerman and see what she thinks.
Yeah.
How should it be
Mhm.
calculated? Because she may say that it's not POA because the shock occurred during the stay. The patient
Yeah.
crashed, and it was moved to a higher level of care.
Mhm, mhm.
So
Okay,
yeah,
I'll
so
check
you
with
really,
her.
you really want to. That's when you want to look to your coding department to see what their take is on that.
And I'll reach out to the doctor too, because I'll be there on Tuesday. So hopefully I can see that.
Yeah. Okay.
Oh,
All right.
speaking of query responses.
Yeah, that's all right. We're going to go through them shortly. And understanding query responses. So as a CDI specialist, queries are sent to the providers, right, for diagnosis specificity, POA status, conflicting diagnoses. I see that all the time. And to obtain accurate diagnosis for final coding in the patient's hospital stay. So query responses will vary between healthcare organizations, though, right? Based on what you capture within the reporting system of their CDI dashboard. So, of course, our response is what we were just hitting through. Generally, they agree with our clarification, and they specified out the diagnosis being queried. Disagree response, they disagree with the query. They give you something totally different. Other response, a provider indicates another valid diagnosis for us. No response, they don't even look at it. And this may be tracked with unable to determine responses. So unable to clinically determine, provider unable to clarify that query response, and those could be tracked with your no responses. So no response and unable to clinically determine responses may be tracked within your CDI program software, where your manager or supervisor, when they run those reports, they'll have a separate classification for those. Now your MCC metric, usually the metric for this is part of your secondary diagnoses, as we know, because we capture CCs and MCCs as secondary diagnoses. And usually your capture rate could be 95%, whereas one facility may have a capture rate of 85%. So again, it varies between healthcare facilities. And then the PEPA report, this is a program for evaluating payment patterns, electronic reports. It's a report that can assist the facilities to determine realistic goals for each organization. So it's mainly a risk monitoring program for billing practices. And it compares different facilities within your region and what the national practices are. It involves all Medicare claims. HMOs are not part of this PEPA report. It's just Medicare claims from CMS. And usually this report is obtained 4 times yearly on a quarterly basis, and it's based upon CMS fiscal year. So we know CMS fiscal year starts October 1 of every year, and then it goes to the following. So we are currently in fiscal year 2024 for CMS, okay? This report assists the healthcare facility if overcoding or undercoding occurs, because it gives you the DRG of the different MSDRG assignments for the different claims that were submitted to CMS. But the facility needs to have at least 11 claims within the specific target area in order for the PEPA report to calculate. Okay. This is an example of the target areas, what the PEPA report will calculate. They will look at stroke, they will look at respiratory infections, simple pneumonia, sepsis, of course, your unrelated OR procedures, unrelated to your PDX. They will look at CC, MCC captures. They'll even look at single CC, MCC capture rates. Okay. They go through, these are quite a bit. They go through 30-day readmissions too. They also look at 2-day and 1-day stays. So the PEPA report usually is received from the quality director gets the PEPA report. So it's really up to your quality department to send this information to HIM and also to case management. Why? Because they have medical necessity 2-day stays on here too. So that would be helpful for the case management department to take a look. And that 3-day sniff, they have to stay in the hospital 3 days before they can transfer the Medicare recipients, right, to sniff for rehab. So I thought this isn't they're abbreviated titles for this, but I thought it was just helpful to know what PEPA reports are from a CDI point of view. And this is just one example. This is medical DRGs with CCs and MCCs, and surgical DRGs with CCs and MCCs. And then the interventions. This is what they look at, possible coding. So if you're above the 80th percentile, you may be overcoding stuff. If you're below the 20th percentile, you're undercoding certain things. So you're not capturing that information for that MSDRG assignment. That just gives you an idea. That's just the definitions, okay? And what interventions are used. Any questions on that? You guys see the PEPA reports?
Yeah, mine finally refreshed.
Okay, you got yours. Okay, but do you actually see the facility, the PEPA report at your facility?
No.
I do.
No? Yeah.
I see it
It's
monthly at our facility.
Yeah, you get it. Well, you get it from quality, yeah, which is good. I think it's really important to get an idea of what PEPA reports are all about, because it does go hand in hand with CDI.
Well, and I'm glad you shared that, because half the time I really didn't quite understand. I mean, my supervisor would go over it, but I didn't understand the purpose of it.
Right. So now you got some little tidbits.
Mhm.
When it comes to denials metric, of course, this calculates the percentage of claims denied by payers within a specific time frame. And denied claims, they can be tracked from payers based on what type that was sent. It could be a deletion of a CCMCC diagnosis, revision of a DRG assignment, or a clinical validation review and or missing documentation to support a specific diagnosis that has been billed on the claim. So determine the type of denied claims and create a tracking system for the denied claims. That's the goal here. You really want to make sure you have the paper trail, so to speak, but this time you have a Excel paper trail within your computer program. And usually the CDI supervisor or manager or coding supervisor manager and or the HIM manager or director will keep an eye on this. They'll monitor this. The billing office or the business office is also involved. Sometimes they may have a designated denial, like a denial coordinator, that she sends out the denied claims to the appropriate department. Like if it's a medical necessity denial, she'll forward that to the care coordination director. If it's a DRG denial, she'll send it to the HIM director. Okay. So there's other departments that are part of the denials metric, and it's not just CDI and HIM. And then the DRG recon metric, this metric relates to the percentage of charts reviewed by the CDI specialist to determine if the CDI and coding have the same MSDRG like we've been discussing. And this is also an internal metric for healthcare organizations that they can track different items. You know, is education for the CDI staff needed from a coding perspective? What type of mismatches between the work and final DRG assignments are noted by the CDS staff? So that's where your education, the feedback for the CDSs come into play with this DRG recon. Keep in mind, though, there's other variables, right? You may only look at that chart once, right? And then it's gone. You know, they're discharged or whatever. So you may have new clinical evidence or new documentation in the record you didn't have a chance to look at. You know, maybe they had surgery. They had surgery. You didn't have the op report. You didn't code it yet. Well, guess what? The surgery happened the second day after you reviewed that record. So, and then guess what? The patient was discharged to a SNF post-op day 2 or whatever, and it didn't come back to your work queue. So, you know, there's always variables. And I think it's important that you have a communication process between the CDI specialists and the coders because it is essential to discuss the recon, you know, the mismatches. And healthcare organizations usually have some type of policy in place, you know, for the discussion of mismatches, DRG mismatches. And the CDI and coding education is usually developed based upon the results of this metric. You know, educational opportunities for both teams, maybe one-on-one education for a CDI specialist and or coder, and then even second level review escalation if the CDI and coder do not agree with the final DRG assignment. And that's what we were discussing earlier when it comes to this metric. Okay, are you all still with us?
With that reconciliation, useful. It was so nice in our facility that the one that's doing the reconciliation is both a coder and a CDI. So because sometimes when you question the coder, they'll throw you what is it the coding clinic. This is what a coding clinic says, right? Yeah, yeah. So you don't know the coding clinic, you know, not that intensive, but with him as a coder and a CDI, so they can throw them the coding clinic and why it was queried. So it was a good a good what do you call this
Teamwork.
teamwork. Yes, a good teamwork for
Education.
uh-huh, uh-huh. Yeah.
Absolutely. Okay. So this is what we're going to use as the CDI specialist productivity analysis for our case scenarios here. Okay. And we have the CDIs listed from 1 to 18. And then Christy's going to go through this for us, right?
Yeah,
Okay.
as you could, yeah. Here, the facility has these goals for KPI with expectation of 25 charts review daily. The productivity is 95 to 100%, response rate is 95%, query rate is 25%, agreement rate 95%, and denial rate is 2 to 5%. With the above data and below is the CDS Specialist resort, which will the manager, director, or CDS be concerned of?
So let me go back to there.
No, I put the thing.
Oh, you put it down there. Oh, that's
Yeah,
right.
yeah.
Okay.
So the average review for this person is 100%. Is the goal is 23.38. I'm sorry. Query rate is 25% goal, and that CDI has 25%. A response rate 95% at 97. Agreement rate 95%. The goal was 95%, and that CDI 92%. So which do you think would be the concern for the manager or the director?
Well, the agreement rate is lower, but also the average reviews per day, 25 charts per day. So they're not quite meeting their goal of 25 charts.
That's right. Yes. Yeah.
They might have
So
go
yeah,
ahead.
they might have like some meeting or something. So you have to, the manager will usually check it out and see if there's like, they call it downtime. So that CDI is only meeting 23.8 chart per day, which is like 1 point something chart missing, right? So, but you're right also on the agreement rate because the goal is 95% and this CDI is only doing 92%. So usually the if it's consistent that way, the manager or the director will have a one-to-one meeting with that CDI and see what the problem is. So that would be your concern is the review per day as well as the agreement rate. Perfect. Good.
And it's
Yeah.
also really important to let your supervisor know if you have issues, because I know sometimes we have so many VDI issues with ours. And, I keep thinking, oh, it's been 10 minutes worth of issues. So you think that doesn't account to much, but if that 10 minutes you
It
can't
does.
do anything,
Yeah.
Canada,
That's true.
because then you're scrambling to make up, and then you might, if you have other issues. So it's important to keep the
Yeah,
supervisor informed too.
that's fine. So
Right.
every month, no, every 2 weeks, I think we submit a downtime. Like I will tell the manager, our computer was down for an hour, or this and that. So at least when that manager looks at the productivity, then I could be justified why it's lower than the goal.
Mm-hmm.
Right.
All right. Here's
Kim,
the
you
question.
wanted to mention something?
Yeah. So, all right. So we understand that the average review and the agreement rate, but like if you're reading this question, which one it says which one, and you gave us two,
Oh,
and
okay.
I want
I mean,
to understand
yeah, so,
exactly which one would be the most priority
yeah,
versus.
probably which would be the most priority, or yeah, we could revise that question, but the goal of the question is which will be, the concern of the manager or the director when you see
Right.
this.
Okay, so they'll be
So
concerned with those.
Yeah,
The reviews per
they
which
would
day.
of
be concerned
those?
with both.
I should have said which of those will be a concern for the manager or the director. So
Right.
yeah, thank you.
But the one thing that I think the key is for the director would be the agreement rate.
Mhm.
Because that's telling me, okay, they're writing queries, but they're not getting their agreement rate over 95% or equal to 95%. So how are they writing the queries to the providers? Maybe they need education on that. See what I mean?
Okay. Yeah, that's most
Yeah.
concerned.
So
Okay,
that would
thank
be one of the top concerns where of course, your average review rate is also another concern.
correct. Okay, thank you.
Mhm. Welcome.
You're welcome. Okay. So case definitions for number 1. The facility has. Go ahead.
Go ahead, Emma. Oh, the facility has these goals for KPI with expectation of 25 charts review per day. So productivity is 100%. So CDS will need improvement since goal was not met, only made 23.8 like we discussed. And the response rate, the CDS met the expectation. So the providers engaged. The query rate also met the expectation. Agreement rate, like Deb said, CDS will need improvement since goal was not met. It was only 92%. And disagreement rate, one can assume there were no disagreements with provider regarding the queries. So, and we already discussed that. Mm-hmm.
Okay. Case number 2.
Okay, so this is case number 2. Um, we have the same expectations, and this is the result below. So the CDI number 4 had 24.2 reviews per day, and then the query rate was 16%, response rate is 91%, and the agreement rate is 94%. So which one would be a concern for the director and the or the manager?
Query rate.
Query rate, you're right. Because it's only 16%, while the goal was 25%, right?
I mean, even at 16% with a 94% agree rate, that's good. But if they had more queries, they would have both a higher average review per day, and then a response rate would be higher because you'd have more queries done.
That's right, yes. So the query rate would be the most concerned because it's really low at 16%, while the second one would be agreement rate, but it's not so bad. I mean, the response rate, which is only 91%. So it's going to be a problem because your query rate is low, so your response rate is also low. So overall, probably there will be a conversation with this
I had a question
CDS.
on this. One of the variables would be surgery, because surgery sometimes you don't get all the time get queries. So what type of program would this person be on? Are they on a particular surgery? Are they doing different types of patients? Because in our facility, we do different varieties. So we do surgeries and we do medical. So you can get an equal amount of queries either way. But if you're typically in a surgical facility, that's going to be very, very difficult. Those are not the easiest to get.
That's right. Yeah. In this facility, it's one facility, so you do it all. So you have a variation of cases. But like you said, some facilities have specialty. So like if you are assigned to a surgical floor only, then your query rate, of course, will be down because there's not much query you could ask for a surgical patient. So this goal, what I'm presenting to you is just a facility which has all the services that the CDS is reviewing. But like some facilities have their own specialty. Like one of my coworkers before was just doing OB. How much can you do OB? So they have a different set of standard or benchmark for specialty floors or cases. So, but this particular case, it is all services in this case.
Yeah.
So this is just what I just discussed to you about what needs to be done or why it is supposed to be looked at by the director, manager, or the CDS.
Okay.
Okay, scenario number 3. The CFO was reviewing the case mix index for the month of February, which was 2.5. He then compared the case mix index in January, which was 3.4. Should the CFO be alarmed with the result? What is the role of the CDI specialist?
Well, there is a concern it went down, but why?
Right.
Yes. Uh-huh.
I was going to mention that January is shorter than February, so of course you're going to have numbers variations
That's
on that.
right. Uh-huh. So you could say that to the CFO. Well, there are only 28 days. March 30,
That's
January is
right.
31 days. So that may
Unless
be
it's a
one
leap
call.
year.
They have to, oh, you're right. Okay.
That's funny.
Okay.
So let's see the next
Well,
slide.
here's the scenario.
Uh-huh. So second question should be the second question, CDI should review the CC and MCC capture. So in the facility I used to work, they have they give us a list, or if you want, we could research what is the CC and MCC capture during those time period. So see, did you capture CC or MCC, or was there no CC or MCC, right? And then check most of the charts are reviewed, so there are missed opportunities for unreviewed charts because even though you wanted to review 25, but there were like, 35 admissions. So you missed the opportunity for, 10 charts. There could be some, query opportunities there. It could be a surgical case that, that wasn't included in your stat. So the missed opportunities usually for unreviewed charts. And then check for the response rate of the providers, may need education reinforcement or engagement by the PA or the CFO. So at Memorial, the PA is involved, but if the PA is he works with the CFO, so they always have a monthly meeting. So they discuss this about the CDI program and what their expectations are. So education is very important, and reinforcement and buy-in by the CFO and PA is also very important. And check what majority of services admitted during the month. Like Patricia was saying, is it a medical versus surgical? So one time the CFO was asking me, well, about exactly the same thing. So I looked at the what do you call this? The services on that particular month, and first of all, it's a short month, and secondly, there's like only two open heart surgery and just a few what do you call this, ortho. So but then in January there were more surgeries compared to February, so that would also affect the CMI because of the relative index, right? The relative weight. And they check whether the symptom DRG are admitted as inpatient instead of outpatient, which is supposed to be observation, which can bring down the CMI. So if the patient has, for example, has um, CAD, right? But then the doctor's been documenting chest pain only, or the patient's angina, or something more than chest pain, a diagnosis that is associated with chest pain. So we could check that the coder coded this the symptom diagnosis instead of what is a higher relative weight DRG. So we could look at that too. And then coding accuracy, like the mismatch, and then the patient's population. Do you have a younger generation or you have an older? If you have a younger generation patient in particular month, of course they have less, comorbidity or mortality, while an older population have more chronic illnesses, which you could query. And also the annual updates to um, relative MSDRG weights. So there's some annual updates. So you could also compare what were the relative weight of the MSDRG. So that would be one of the many that you could check if the CFO is asking you, because usually they will come to you or to the manager and say, "Hey, look, the CMI is so low now. Why is it high last? So what was the discrepancy there?" So these are just one of those or all this information that you could look at so you could defend yourself.
All right.
Mm-hmm.
All right. Very good.
Okay, The facility has an expectation of query rate of 25%. The chart review daily is at 25 charts. How many queries should the CDS do per day on the average? So I just put here the calculation. So if your expectation is 25%, so you have 25 and a query rate of 25%, I'm sorry, and chart of 25 charts to review. So if you have 25 charts per day times 25%, that will be equal to 6.25 charts that you should do per day. But like on a Monday, I mean, you cannot you're not expected to do that. So uh, my personal experience is I try to catch up for the whole week. So sometimes I have less on Monday, but I'll try to catch up, Tuesday, Wednesday, Thursday, so I could reach that expectation, the 25 charts.
Right. Does that make sense, everybody?
Mm-hmm.
Yeah. Okay. Okay, so in summary, we reviewed the policies and procedures associated with CDI processes, query processes, as well as daily metrics within a healthcare facility. The CDI metrics KPIs will vary from each healthcare facility based upon the size of the facility, types of patients admitted to the facility, as well as any procedures that may impact your MSDRG assignments. CDI specialists need to understand the coding guidelines and create compliant queries for providers to obtain the highest level of specificity for each diagnosis within the medical record. CDI specialists also need to understand the query responses as it relates to the CDI metrics or our KPIs. And CDI specialist coders need to have a general understanding of the PEPR report for compliance and risk monitoring of hospital billing practices, as well as CDI specialists and coders need to understand the denial process associated within their healthcare facility for prevention of future denials based upon DRG assignment and MCCC captures. Thank you for joining us today. Any other questions?
Mm-mm.
Yeah, I have a question. Is there any other reference material out there for metrics for review for the CCDS exam?
CCDS? Okay, is it the ACDIS CCDS you're referring to?
Yes.
They do have, ACDIS has the test guide.
Yeah, the study
So,
guide.
yeah, they have the study guide. I would suggest definitely getting that one.
Yeah, I got that. There's not a lot of metrics in it, so we just really wanted to make sure.
Yeah.
This has helped
I know.
tremendously. Thank you so much. Yes, thank you.
Well, I
Yeah.
hope this was helpful then. Okay, good. Because
Yeah.
I noticed in the CCDS, handbook, their study guide, they didn't have a lot of metrics in it. And I was like,
No.
wow, that's interesting.
And-
I know they will focus on quality stuff.
do.
So,
Okay.
and the PSI 90, I know that was part of it. Debbie, when did you take yours?
I haven't.
Oh, you haven't taken it yet? You're going to take it though this year, right? Or next year?
Well, I probably won't get it done this year, but excuse me, but next year I want to take
Yeah.
it, and it's been too nuts this year to concentrate on it.
Yeah, understandable.
Mhm.
Yeah.
Yeah.
But I know somebody just took it. One of my contract colleagues, she just took it and passed, and she's been doing CDS 4 years, and she took it, and I can ask her, Kim, to see what was on it, what she remembers, and then I can email you if you like.
That would be awesome. Thank you. Yes.
Yeah.
Information.
Because I know they did it. I noticed the study guide because I usually
It doesn't have a lot of
purchase.
metrics, but
Yeah, they did it.
I
They
assume
didn't.
the test is going to be a lot of metrics.
Yeah, I was going to say the
Yeah.
people on the ACDIS forum on Facebook were saying that there were metrics on it, which is why I wanted this class so much, because that part's so confusing to me.
Yeah.
Yes.
Yeah.
Mm-hmm. Yeah, it's just understanding how they, how the management is measuring your performance, and it's all the numbers. And if you know you should know that, like I said, its facility is different, but at least you would understand the rationale why they are, what is this for? Why is the, productivity important? Why is the response rate important? And, and knowing, their, what do you call this, their benchmark, what their goals are, and what are the results. At least you would, that's why we presented those cases. At least you know which are, a red flag, when you see those numbers based on the benchmark. So
Right.
yeah, because I remember I took my CCDS a long, 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 long time ago,
Long
and yeah,
time ago, like I did.
so, but there were metrics. So I didn't even know that it will be with metrics, but there were metrics, question, probably two questions
Have you
about
guys,
that.
Christy and Anne Marie, have you considered doing a CCDS prep class?
Um, well, we're looking into it, but we have to make sure that, we will get all the information first, because we want to make sure that whatever we teach would be. But we are looking at it, Debbie. Thank you. Mhm.
Yeah.
Oh, that would be awesome. Yeah, we
And
Mhm.
then
That'd
you
be,
Yeah.
yeah, a lot of people keep asking us about that.
I
Yeah.
keep asking because I'm praying and hoping. But do you have to
Yeah.
go to somewhere to take it, or do you take it at home?
You mean the test?
Yeah.
Before we took it
Oh.
in, it was in H&R Block where I took it. So it's
Yeah.
an office.
We
They
took it at
would,
a test site.
Okay.
yeah, that's
Yeah, we have a,
that's what it is.
I
It's a
believe,
site. Mhm.
Kim, do they offer it online though? You can do an online testing too with a proxy.
yes, you can do that. Yes.
Mhm.
Yeah, they have
Mhm.
that option now for online since COVID. Yeah.
Mhm.
Okay.
Yeah,
Mhm.
Yeah. So,
but there is a test.
right.
Yeah.
Okay. And here is all
Okay.
the references that we used for this. Like I said, this is the Rodenberg, Howard, and James Campbell. That's the article regarding the national CDI metrics model. That's the article I found. I thought, like I said, it was pretty interesting, and it's part of NIH, which is the National Institute of Health website. So I thought that was pretty interesting to bring it in and what the senior leadership needs to understand. Okay.
Thank you for watching. Don't forget to click subscribe, follow, and like buttons. Click the link on the description below to obtain continuing education.